tell me a little bit about the association, what you guys do, and what your big goals are.
Yeah, so the National Association of Rural Health Clinics is the organization solely and specifically representing the nation's 56 to 5,700, we're really close, rural health clinics across the country. So the rural health clinic designation is a specific designation given to facilities in rural, medically underserved parts of the country. Like I said, there are about 5,700 of them now. They provide care to about 39 million Americans. This designation is a specific Centers for Medicare and Medicaid, or CMS, designation given to rural health clinics who go through a survey and certification process, meet that other criteria. With that designation comes enhanced traditional Medicare and Medicaid reimbursement for those facilities. So since the program was created in the 70s, Congress has recognized that it costs more to deliver care in rural areas. They help subsidize that access and the ability to continue providing care in those communities through the Rural Health Clinics designation and other program designations. So our facility specifically represents those provider types. Like I said, they're providing outpatient care. That's a lot of primary care services, behavioral health, and some specialty that they provide as well in these rural communities. And so we are here to be their advocate here in Washington, D.C., be their voice at the table in a lot of these policymaking conversations. And then a lot of our work too is educating the clinic directors and providers and other staff at these facilities about what their designation means, what it grants them access to, and then how to comply with all of the rules and regulations governing their program.
And this really does focus on rural communities. Can you kind of give me a definition of what is a rural community?
Yeah, so one of the challenges is that there are actually a lot of different definitions of rural communities, even used at the federal government level. So the USDA uses one definition of rural for different grant programs. They have the Federal Office of Rural Health Policy uses another, and then the Census Bureau uses an entirely different one. So it can be challenging to define a rural community. I think another important part about that, and one that your audience may know well, is that rural communities look very different even within a specific designation. So we have everything from, what you may think of as more suburban communities that actually meet some definitions of rural, the whole way to like frontier rural communities out in like the more Midwest parts of the country. And so the definition that we specifically use in terms of rural health clinic eligibility is areas of less than 50,000. And so to be eligible for the Rural Health Clinics program, populations of less than 50,000, and also, again, they're in a medically underserved or health professional shortage area.
And would that be 50,000 less in a county or in a city?
Yeah, so it's based on census definitions, and those are in kind of like population hubs and like census tracts. It's a little bit complicated. There's a lot of maps out there if you wanted to dive into it. But again, this is one of the challenges. A lot of areas may have an underserved component but may not necessarily be rural, or vice versa. And so a lot of the work at the federal level is making sure those designations make sense. Sometimes they need to be updated as the population evolves, but it can be some like pretty complex formulas in establishing those.
And I'm not sure, if you have, been able to look, for the Mahoning Valley itself inside of these charts. We have Trumbull County, Columbiana County, and Mahoning counties that make up the valley.
Yeah.
Do you know where any lines of like rural would be in those communities?
Yeah, I think it's challenging to find like specific lines for those. Just like with most valleys and most counties, there are rural, suburban, and urban areas. I did look a bit at the map though, and there are certainly some very, very rural populations within the valley, and there are rural health clinics in the communities as well.
Yeah, absolutely. And then we know that, these rural communities, as you already looked into as well, were telling me that they have a lot of hurdles that they need to overcome. And it can be, more expensive. Some have population loss that they're dealing with, technology. The list goes on. What really are the biggest challenges that you guys are seeing when it comes to rural healthcare?
Yeah, absolutely. There are a lot, but I'll name just a couple. So provider and other staff recruitment is a huge challenge. We all know the value and the unique positive nature of rural communities, but sometimes that can be challenging to communicate to potential providers and their families interested in maybe relocating to these communities to help provide care. And so recruiting and retaining these providers can be really challenging in rural communities across the country. There are some really unique opportunities to practice care, to practice a wide range of medicine that oftentimes once providers experience delivering care in rural areas, it's something that they want to continue to do. But getting their foot in the door, getting them there in the first place can be really challenging. So there are a lot of loan repayment programs that are really valuable that a lot of clinics and other facilities use. There's a lot of value in those, and just some other really unique solutions that clinics have found to bridge those gaps. Another one, just an ongoing challenge, is volumes-based in rural areas. So just like in any other urban facility, they have certain staffing ratios that they need to meet. To keep an emergency department, for example, you have to have staffing 24/7 in those facilities, but you may not see a patient for a couple of hours. And based on how our reimbursements are structured in this country, you receive reimbursement when you see a patient, when you provide services. If you go a period of time without providing those services, because it's a good thing there weren't perhaps any emergencies in your area, then it can be really challenging to remain operational, remain viable, because you have to keep those same staffing pieces. And so volumes-based can be a challenge. We feel this less on the outpatient side of things because there are a lot of folks in rural communities that have a lot of chronic disease. They're an older population most often, and so there's a lot of reasons that we get them in the door for preventive services, for management of those chronic conditions. So less of a volumes challenge on the outpatient side of things, but in rural communities we also want to be able to sustain that inpatient and emergency room care. Volumes can be a really big challenge there. And then lastly, I'll just say the evolving payer mix in rural communities can be challenging. We have traditionally a higher Medicare and or Medicaid payer mix, so higher government-sponsored healthcare in rural communities based on the population makeup. But that shifts. There are shifts from traditional Medicare to Medicare Advantage, back to traditional Medicare. There are folks that lose Medicaid eligibility and then they're eligible for marketplace plans or employer-sponsored coverage. But I will say, as a rural health clinic, every time that someone's changing insurance coverage, in addition to the patient challenges of navigating that system, the facility has to also ensure that they are contracted with that payer if necessary, that they are going to be reimbursed. What type of system does that payer use for prior authorizations, for example, and claims payments? And so it gets really complicated fast, but every single plan that they're contracted with has a different structure for doing so. And I think this just adds to the administrative responsibilities in a healthcare operation. They have the same amount of rules and regulations, sometimes even more in rural areas, to comply with, but they're doing it with a more limited staff and lower volumes across the board. And so this can be just challenging for keeping up staffing and keeping aware of all the changing things.
Yeah, and I do want to expand a little bit more when it comes to staffing.
Yeah.
Who are you seeing more lack of? Is it lack of doctors? Is it lack of primary care? Is there certain services that people can't get?
Sure. Yeah. Again, every rural community is a bit different, so I'll give that caveat. But care in rural communities is provided by a broad range of practitioners. In rural health clinics specifically, we see a lot of care provided by advanced practice practitioners, so nurse practitioners, physician assistants, clinical social workers fill those needs quite often. I will say there's, in addition to the providers that we need that are providing the care in rural areas, there's also a challenge with the other staff that we need. So those billing experts and coding experts, IT professionals is another big one as we see this rise in healthcare, like cyber attacks in particular. You need competent IT professionals to help manage your systems. This is another area that I think is not talked about as much in terms of the staffing we need in rural facilities. We think, of course, providers, let's put investments into their loan repayment or getting them into those facilities, but we think less about kind of the broader staffing model that includes all of those support personnel, leadership, that kind of thing. We need those professionals as well.
And what are some examples of training opportunities that you do give or that they give to these groups, to try to help fill this gap and try to find more staff, or their lack of these opportunities?
Yeah, to a degree, I think there always will be a lack of those opportunities. I mentioned loan repayment a few times. National Health Service Corps is a really big program that helps to bring these practitioners into rural communities. When they practice for a period of time, they get a certain amount of their loans forgiven, and that's incredibly valuable for these practitioners who need to pay those loans back, and so they're looking for places that they can practice, get those experiences, and then have their loans reduced at least slightly. I will say, I think the responsibility for tackling some of these training opportunities or lack thereof is both on the schools, is both on the federal government and also the facilities themselves. So I think we try to encourage a lot of colleges and universities that have a nurse practitioner or a physician assistant or an MD training program to have a specific rural health track for their practitioners to get the experience in. There's a lot of research that shows that when a practitioner is able to train in these rural communities, see the unique nature of these communities, all the different types of care they're able to provide. They're seeing babies and also the elderly, like all in the same day in their facilities, and there's a lot of value in training experiences for that. So there's a lot of data that shows when they train in those communities, they're much more likely to return to those communities to practice. And so I think the more that colleges and universities can offer that option or that experience to these individuals, the more likely they'll be to return. And then also the facilities themselves, it's important that they have those training or rotational opportunities available to the students as well. It can be a challenge, again, for these small rural facilities to wear yet another hat and have another responsibility of having a student trailing them throughout the day, for example. But the earlier that we can expose these students to these opportunities, the more value there is in that. And so last thing I'll note on this, but the National Association of Rural Health Clinics has a research and education foundation, and part of what the foundation does is offers stipends, scholarships to nurse practitioner and PA students that are completing clinical rotations in rural health clinics to help give some of that experience, some of that introduction and exposure to what it's like to provide care in rural areas.
And are those ultimately like partnerships between these healthcare systems in rural communities and the educational systems?
Yeah, so they need to have some type of preceptor arrangement in place for those current NP and PA faculty to have these students rotate within their facilities, learn from them, they can sign off that they're achieving their clinical competencies, that kind of thing. So oftentimes it is those relationships, and when we're able to, we try to help facilitate those, just so a facility is not kind of looking for any program. We know those that are out there, and we can kind of help to make some of those connections.
And I know that there's no final definition here for rural, but when we look at these kind of areas and what we want to be seeing here and going into population, how does population really go into rural health clinics and hospitals? Does that really lead to any concerns when there is less population?
Yeah, so this goes into the volumes that a facility sees on a daily basis. Volumes is a big challenge. Declining populations leading to declining volumes in these facility types is a big threat to their financial viability, right? Again, if you have a facility you have to staff 24/7 in the case of an emergency department, but you have a declining population in your community, and maybe you don't see a new admit for several hours or maybe a couple of days, your inpatient census is really low, you're not getting a reimbursement for just keeping your doors open, right? You get a reimbursement when you see patients. And so a declining population, will lead to declining volumes and threats to your viability. And we measure the eligibility for the Rural Health Clinics program and other facility designations through one of the things I mentioned, a health professional shortage area. So that's, or a HPSA, that is the number of practitioners that you have per 1,000 people in your community. And so those shift a lot. The need in a community as they see populations ebb and flow can really vary. And that all of those pieces work into the calculations for different loan repayment eligibility, other grant opportunities. And so, yes, we in rural communities, a lot of times we see declining populations. That's what I would say talked about the most. But there are certain rural communities that are seeing really a lot of population growth because of perhaps some tourist attractions they have, or they're a nice place to retire. And so we're seeing population growth as this next generation ages. So each community, I keep saying that, but each rural community is so different, and if you've seen one, you've only seen one. And so I think that's what's really neat and challenging about my job at the same time, is that I get to represent all these different communities and try to advance their priorities here in DC.
Yeah, and I do want to take a little bit of a shift to, some of the federal dollars that are given to these communities. The big beautiful bill specifically is, part of that is to cut $1 trillion, in Medicaid. How do you think that's going to be affecting rural healthcare as a whole?
Yeah, we have significant concerns about the impacts of HR1, or the One Big Beautiful Bill, as it's been named. There are a lot of changes to both Medicaid and the Affordable Care Act and marketplace plans. It's challenging to know immediate impacts of what this bill will lead to. There's obviously a lot of estimates out there from the Congressional Budget Office. 10 million will lose health insurance coverage over the next 10 years, or some of the estimates from that. We hope that they don't play out in quite that estimated way. That's a significant amount of coverage loss, and kind of a backslide from a lot of the positive changes that have occurred that have led to a higher insured rate in this country. So we have a lot of concerns. A lot of these provisions, things like work requirements for the Medicaid population, increased eligibility checks, and a variety of other provisions. I think part of our responsibility as advocates for this program and educators to the rural health clinics themselves are around what are these provisions actually doing, and what impacts are they going to have on your facilities. So we'll talk about work requirements, for example. On paper, I think a lot of people are very supportive of work requirements in exchange for the federal benefits that you receive, right? But in reality, what work requirements tied to the Medicaid program actually look like are a lot of additional red tape and regulatory requirements, and proving that individuals are actually working. I think it's KFF says that 92% of eligible Medicaid beneficiaries are already working or have an exemption to what those requirements would be. A lot more than 8% will actually end up losing insurance coverage per these estimates from the Congressional Budget Office because of navigating that red tape. What that ultimately means for facilities like rural health clinics across the country are that their population, that they are used to being a paid population, right? They are covered by a payer. When they see those patients, they receive a reimbursement for those visits and those services that they're providing. They no longer will receive reimbursement when those patients lose coverage. So they're in that uninsured or self-pay bucket. What that ultimately results in is facilities are providing more care and not getting paid to do so. And it's not hard to see the domino effect of less reimbursement to your facilities, and you're still paying the same providers. You still have to keep the lights on in your facilities, and ultimately you're not financially viable as a provider, as a system anymore, as you provide more uncompensated care. And so that's a big concern, just one of many coming from this legislation.
And specifically in the Mahoning Valley, we actually have a higher than average poverty level just across the 3 counties. How is that? Are we going to see a bigger impact from what you've been looking at than maybe a community that has less of these poverty levels?
Sure. Yeah. If you have a higher currently Medicaid population or dual eligible, so Medicare and Medicaid population, and the coverage losses across the board do play out the way that they're estimated to, that's going to hit communities that have a higher uninsured population to start, and a higher Medicaid population as well. Again, because as more of those folks lose access to healthcare through their insurance coverage, that doesn't mean that they stop showing up to the doctor's office or to their local emergency department. It just means that those facilities don't receive payment to care for those individuals. It also means that those individuals are less likely to seek care as quickly, right? I mentioned that in rural health clinics we provide a lot of preventive and primary care services. When a patient doesn't have insurance coverage, data shows they show up to the doctor later. That means they're sicker and their care is more complex and more expensive to treat. And so it's more expensive on the facilities, it's worse off for the patient, it's more expensive on the facilities, and then they don't ultimately receive reimbursement to provide those services. And so they continue to get, unfortunately, further into a negative financial situation. And facilities, don't go into I hear all the time, facilities don't go into rural healthcare, individuals don't go into rural healthcare to make a lot of money. They just want to break even to keep their doors open and continue to provide care. That's certainly becoming more challenged by a lot of these provisions, and just a lot going on in the federal policy environment. And there are a lot of real concerns from facilities about what that will result in.
And something particularly that was in this bill now, act, is they mentioned that there's also going to be an additional $50 billion that's going to be given to these healthcare facilities in rural areas. Do you think that will offset the damage that'll be done from the Medicaid cuts?
Yeah, so it's certainly not a one-to-one. I will say the Rural Health Transformation Fund, like you said, $50 billion for an investment in rural communities is the type of investment that we and other advocates have long time supported for rural health, right? There are certain areas where we certainly see an opportunity to transform what delivery and access looks like, and so that's wonderful. The way that this fund is designed, there's a lot of unanswered questions to start, and it's certainly not a one-to-one in terms of making up the difference between what the estimated losses are going to be from a coverage and therefore revenue perspective. Certainly not one-to-one. But also, this money is allocated from CMS to the states. And so there's a lot of unanswered questions about what those applications will look like. That money needs to go out the door by December 31st of 2025. So not a lot of time for applications to come out, to be completed at the state level, and for that money to be issued by CMS. But ultimately, once states get that money, they then have a lot of the authority as to what to do with that money. So it's not like they're required to give every rural facility in their area X number of dollars. States can choose to use this for a wide range of things. So some may give direct provider relief to these communities. It's based on the pot of money and the number of rural facilities. It's still unfortunately not going to be a one-to-one replacement of the dollars they're likely to lose, but states may, see the need in giving that. Other states may do a more widespread rural health transformation program. That obviously is not that direct relief to those providers that I think a lot are really hoping for at this time. There's a lot of also, concerns and frustration by some that half of that $50 billion is going to go evenly to all states that submit an application. There's obviously very different rural populations in different states across the country, and half of that money is being distributed equally. So I think there's some concerns about what that will look like and what different states will have the opportunity to do with those funds. But at the end of the day, the type of an investment we're pleased with, but we just wish that it had come on its own and not with all of these other cuts.
Yeah, and then, this really just seems like there's a lot of uncertainties of what this will be causing for hospitals, but something that you mentioned to me is that there might be some rural, healthcare clinics and hospitals that could be at risk. Can you kind of just expand a little bit on what you mean by that when it comes to, just kind of expand what you mean on that.
Sure, yeah. So on average right now, a rural health clinic's payer mix is about 26.5% Medicaid. So for that 26.5% of their population, their patients that they see on an annual basis, they know the amount of reimbursement that they're going to receive when a Medicaid patient walks through their door, right? They receive the same amount for every time that they see that Medicaid patient. If now that patient has to prove a variety of other things, prove that they're working, prove their eligibility multiple times per year, just have additional barriers to retaining their Medicaid coverage, even if they're completely eligible per the program requirements. They are less likely to be able to retain that coverage, right? We know that when we increase the paperwork to have a benefit, to have access to a program, folks fall off unnecessarily that would otherwise be eligible. And so as that patient population that we're used to as a rural health clinic being reimbursed by the federal government at an X rate, as that uninsured population increases and that covered paid population decreases, the facility now is really unable to make a lot of the financial projections that they were used to making, being able to understand what their revenues were expected to be in a given year. And now they are treating patients, they are providing services, and they are not getting reimbursed for doing so. And so that ultimately just decreases their revenue, but their expenses stay the same or increase perhaps. And so that's putting them in a financial environment that we don't know how many of them are going to be able to weather that storm, right? Rural health clinics, a lot of rural facilities are very, very resilient, have weathered a lot of regulatory and legislative changes in their time as a facility, but this is a particularly large cut, the largest we've seen. And so there's a lot of concerns about whether they'll be able to keep their doors open. It's really devastating to think about the loss of a hospital, loss of clinics in a community. Many communities across the country have unfortunately experienced this, right? For a variety of other reasons, their facilities have closed in the past. Then those individuals living in those communities have longer drive times, longer wait times to the nearest facilities. That's assuming that those nearest facilities are able to accommodate the increased number of patients that they're going to be seeing, right? And perhaps these patients don't have insurance coverage, and so that's putting a lot of pressure on those closer facilities, even if they're in an urban area perhaps. And so the pressure on the system just continues to grow. It's not a perfect system right now by any means, and I think that's why a lot of these things just feel like death by 1,000 cuts, and a lot of facilities are really questioning whether this will be the thing that means they ultimately aren't able to provide care in their communities anymore, despite all of their efforts and their intentions to do so.
And yeah, you already went into some of the details of what this could cause. It could cause higher waiting times, or it could cause a lot of different things for these rural health clinics. Some of them potentially closing. Can you just kind of go into this a little bit here on why this would be so detrimental to lose some of these clinics and or hospitals in rural communities specifically?
Yeah, I've always been in this role because I believe that every community across this country deserves access to quality and affordable healthcare, right? And the Rural Health Clinics program means that quality, affordable healthcare access is possible in 5,700 communities across the country that otherwise probably wouldn't have that access. People live in rural communities because of a variety of reasons and unique opportunities that they have in those areas. They're really beautiful places to live. There's a reason that, we live here in the city and we travel to rural communities to vacation there, right? Like there's so much value in rural communities to live there, to work there, to raise your family there. It's a lot harder to do all of those things if you don't have access to healthcare, to the basic, you are sick and you need to go to the doctor, to the emergency room. People are a lot less likely to live in communities when they don't have access to healthcare. And so we already in some rural communities are seeing population decline. We estimate that would be severely exacerbated by the loss of healthcare facilities in your communities. Hospitals, clinics oftentimes are also large economic drivers in communities. They employ a lot of the people that live there. Those individuals also then have to travel further just to go to work. And so then they start to weigh, well, do we relocate to those other communities where we're already working and have access to healthcare? And so it's just a very, these things happen gradually to some degree, but again, it's not hard to estimate the really negative domino effect of what the loss of a clinic or a hospital in a community could be.
And something else that we've been talking about is not just Medicaid, we also spoke a little bit about Medicare.
Yeah.
But there's a shift right now from Medicare to Medicare Advantage that you've mentioned. Can you tell me how that's been playing a role specifically in rural communities?
Yeah, absolutely. I'm really glad you brought that up. So, again, the value of being a rural health clinic is when you have a high Medicaid or traditional Medicare population that you're serving because of the reimbursements that you receive from the federal government for doing so. When it comes to the shift to Medicare Advantage, there is no value to being a rural health clinic when it comes to your contracts with Medicare Advantage plans. So for those individuals, those elderly populations that choose to enroll in Medicare Advantage as opposed to red, white, and blue traditional Medicare, they do that for a variety of reasons, right? They have perhaps greater access to supplemental benefits in addition to their hospital and provider coverage. Maybe they have lower premiums every month. Again, there's a lot of reasons that patients choose to make this shift. But from a facility perspective, from those providing the care, again, there's no benefit to being that deemed rural health clinic when it comes to your contracts with Medicare Advantage plans. And because of that, everything is like another commercial contract left up to the negotiations between the payer and the provider. Particularly when we have small, oftentimes independent providers doing the negotiations with large Medicare Advantage plans, the plans themselves have the negotiating leverage in those relationships, not the providers themselves. And so it leaves our providers with low, really low in many cases, reimbursement rates in comparison to what they were used to receiving from traditional Medicare. And so our Medicare, not to get super in the weeds on like billing and reimbursement pieces, but in a rural health clinic, their Medicare reimbursement is based on costs. So there's a whole calculation, they get what their cost to treat an average patient is. That's what they receive every time a traditional Medicare beneficiary walks in the door. When it comes to Medicare Advantage, they're not receiving their cost-based style reimbursement. And so they're consistently getting reimbursed at less than cost or significantly less than cost. And just like when we were talking about the Medicaid dynamics, if you're putting more services, more dollars going out the door in terms of your services and the care that you're providing than the reimbursements that are being returned to you, again, you can only operate in those environments for so long before you have to close your doors. So it's putting a lot of our providers, when it comes to Medicare Advantage, in some really tough spots. A lot of their patients have already enrolled in Medicare Advantage plans for a variety of reasons, but that plan is not contracting with them for something that supports the services they're providing. So we're seeing a lot of clinics, a lot of hospitals and systems leave their contracts with a Medicare Advantage plan, saying if you're not going to come to the table with us and negotiate in something that is adequate for our services, we're not going to retain these contracts with you. Unfortunately, that leaves the patients that are enrolled in that plan in a tough spot because now, they're out of network with the provider that they've seen perhaps their whole life. So the shift is just another one of those dynamics. Like I was saying, it leads to higher administrative burden and administrative responsibility in a facility, right? These are all the things that we're talking about are beyond providing care, right? This is not our providers seeing a patient and having access to care in communities. These are all the other pieces that are necessary for that care delivery, but ultimately are staff time and dollars that are taken away from just the ultimate provision of care. So the shift from from Medicare to traditional and vice versa, so traditional to Medicare Advantage to traditional Medicare, those shifts back and forth are just ultimately really challenging and taxing on a facility as all of these other pieces continue to evolve.
And is that a more newer trend where people are going to Medicare Advantage, or has that been something that's been going on for decades?
Yeah, so Medicare Advantage as a concept, as various plans have been around for quite some time, but really the more significant jump has occurred in the last 5 years or when we've really seen those jumps. I think it'll be really interesting to see over the next several years if that trend continues or if a lot of these other pressures start to mean that maybe that trend slows down or reverses slightly.
Yeah, my last part I really wanted to talk about was COVID-19 really making a huge shift, especially in rural communities. I feel like those pressures are really just stacking on top of each other because of this. Can you just tell me really what kind of effects that you saw when it comes to rural health clinics and, just rural healthcare in general when it comes to COVID-19 in the years following?
Yeah, absolutely. So during COVID, it was really interesting because a lot of folks appreciated healthcare and appreciated healthcare providers in ways that they maybe hadn't had to think about before, whether because they were sick or these were the folks on the front lines treating this virus that we didn't know a lot about at the time. So there was a lot of appreciation for rural healthcare. But unless folks were sick with COVID, in the vast majority of cases, they weren't receiving healthcare. They weren't going to the doctor for that normal preventive or primary care services that they were used to. And so in the wake of COVID, time and time again, I hear from facilities that they're seeing, again, patients that are sicker, more complex because their care went untreated for several years as folks stayed at home, practiced social distancing, didn't go to the doctor, didn't feel like it was that immediate need. Now we see a lot sicker, more complex, more expensive patients to treat in these facilities. So that's one of the significant challenges that emerged from the pandemic. We also saw a lot of creativity, a lot of the innovation. I'm sure this happened in all types of facilities, but I got to see it in rural health clinics specifically. The ways that they were receiving or they were providing care wherever their patients were. So a lot of times in the parking lot and on street corners, they were treating patients just to continue providing this care even when they couldn't physically come into their facilities. So a lot of innovation, which of course was really, really neat to see as kind of shining lights amidst a lot of unknown and things like that. But it certainly has exacerbated a lot of the challenges that we were feeling pre-COVID as well. Certainly from the provider staffing and recruitment, there was a lot of burnout that really came to a head with providers and other staff in healthcare facilities. We're already operating in a challenging environment for provider recruitment and retention and other staff as well, and so that exacerbated the challenges there. So we saw some shining lights, but a lot of challenges certainly that I think we're going to be working through for decades to come.
And is there anything else you would like to add that maybe I didn't ask about that you feel is really important to share for the story?
No, I don't think so. I appreciate you being here and being able to talk about rural health clinics. They're a perhaps less well-known part of the really important healthcare safety net, but they're providing care to 39 million Americans across the country who perhaps otherwise wouldn't have that access. And so that's why it's really important for us to preserve and expand the access to care that they're able to offer.